All right, I'd like to introduce the fantastic Jennifer Van Duzen, who has pulled this together, and she has some remarks to make as you continue to get your lunches, and then we'll get started. Thanks so much for being here.
How about a big round of applause for the unsurpassable Chris Hall, without which none of this would be possible. She's very modest, however, she totally rocks. As Chris said, I'm Jennifer Van Duzen. I'm clinical faculty at the College of Osteopathic Medicine. One of my roles is to ensure that students at the University of New England understand what's going on with the opioid crisis and what treatments are available for patients with severe opioid use disorder or moderate opioid use disorder. So I have a lovely panel here today to talk to you about that, and or to talk with you, not at you, about that. And this is challenging for me. Hi, Biddeford. Just want to say hi, Biddeford. Oh, small group up there. This is challenging for me for a couple of reasons. One is you're very far away. Hi. So really the people sitting closest to the front are the ones who are really going to get the biggest, most illuminating takeaways from this. So if you'd like to move up, that's just fine. Oh, there they are. Much better. Okay. So I do want to thank our sponsors before we start. We are supported by a HRSA grant that was obtained by the Center for Excellence in Health Innovation. So they are sponsoring this. And then IPEC, of course, is a big partner. And the College of Osteopathic Medicine, the College of Pharmacy, the College of Dental Medicine, and the School of Social Work bought your lunch. So when you see your dean, if you are from one of those schools, please tell him or her thank you. We're very, very happy to be able to present interprofessionally to an interprofessional audience. Here are our presenters, and we will introduce them as they go. But just briefly, Jen Gunderman is MPH from Public Health, Masters of Public Health. Did you wave?
I did wave.
Okay. Meredith Norris is a doctor of osteopathic medicine. Can you wave? Thank you. Emily Dornblasser, many of you might know, is a PharmD from the School of Pharmacy. Tessie Stansberry is a doctor of dental medicine from the Dental Medicine School. And Steve Danzig is here representing the behavioral side of medication-assisted treatment. So thank you all for coming. So this is how our session is going to go. And we're going to talk about these topics, and they are related to what our intentions are and how we'd like you to what we'd like you to come away from this session with. So those are our topics. Before we start, I'd just like you to take a minute and to think for yourself, just to ground yourself in your own personal experience of this crisis. This is about people. People of all walks and kinds and types, and we are all people. So some of you, I realize, may have been directly, intimately touched by this crisis that we are now experiencing as a nation. And I'd just like you to give yourself a moment to think about that and to feel that for yourself, so that as we go into this, you're remembering that it's people at the heart of this. And all of you are here because you're in the helping professions. And we can remember our patients first. So here are our learning objectives. And thank you for that opportunity to hold those people in the light. We're going to start with describing the epidemiology of the opioid crisis and the stigma that's attached to that. And so I'd ask you to welcome Jen Gunderman.
Good afternoon. Thank you for having me. As Jen mentioned, my name is Jen Gunderman. I work over at the Center for Health Innovation. I am the AHEC, or Area Health Education Center Director. I've spent most of my professional career as an epidemiologist, so I'm very excited and delighted to be able to talk to you about data. I also have been very fortunate that I have either guest lectured or taught a class in every one of the colleges here in the university. And so I feel very fortunate to be here with you today. So this is going to be a little bit of a challenge for me, being an epidemiologist, aka data geek. I love to talk about data, and so I need to cover that and talk a little bit about stigma in the next 15 minutes. So hopefully we can cover some of the very important topics about the opioid epidemic and around stigma. For my presentation, in order to not keep on stumbling over words, I am going to refer to the acronym OUD as opioid use disorder throughout my presentation. So to get started, to kind of warm us up a bit, we're going to do a little bit of an exercise at your table here in Portland and also in Biddeford. I want you to think about how you have heard the opioid epidemic and people struggling with OUD talked about. And I want you to think about the negative connotations, the myths, the things that spread stigma. You may have heard it from somebody in your family or in your friend circle. It may be something that you've heard on TV or from politicians. And I want you to think about what are those specific things that you have heard or seen. And in about 60 seconds, I want you to go around your table and each person say one of those things that they have heard or experienced or seen that has put the opioid epidemic and people struggling with OUD in a negative light. So let's just take a minute to do that. So go ahead. Okay, does anyone, I know that we don't have microphones at the tables, but does anyone, oh, great, we've got a microphone in the audience. Does anyone want to share either something that they said or may have been said at their table? Just to do a couple of examples. I'll give you an example of something that I've heard in my community. For example, I've heard in my community, why are we giving out Narcan for free? After someone's overdosed a couple of times, it's not worth it to give them Narcan. I've heard that in my own community of Waldo County. What are some of the things that you've heard?
It's their fault.
It's their fault. Mm-hmm.
Yeah, basically, kind of something similar, like, well, why don't they just stop? It's their choice.
It's their choice. Why don't they just stop? That's very often heard. Anybody else want to share? How about in Biddeford? Is there a way to hear them in Biddeford? Okay. Well, one of the points for, someone want to share one in Biddeford? Okay. One of the points of today is to kind of bust those myths. It's for us to be able to provide the facts about the epidemic and about people who are struggling, so that you, as healthcare providers, as people living in a community of whatever your profession is going to be, or your place within your family, your friend circle, or your community, that you can talk about the facts. And talking about the facts is a way of starting to break down that stigma. So I'm going to start today's session about talking about some of the data that defines the opioid epidemic. Oh, and I forget that I've got slides. Oh. So one of the ways so here's your 30-second epidemiology lesson for today. One of the ways that we use epidemiology to understand a health issue is to describe it in terms of person, place, and time. By doing that, we can understand the impact that a health issue has on our community and the implications for our communities, our populations that we care for, and that we can understand extent and impact. The data that I'm about to present is going to focus on deaths due to overdoses. One of the reasons why I'm going to focus on that data in particular is for a couple different reasons. One, because I only have about 15 minutes to present the data, but second of all, deaths due to overdoses, the way that deaths are collected is done in a very routine and uniform way that we can feel pretty confident that the data is as reliable as we would hope to. Data is never perfect. But the data on overdoses are provided on death certificate data, which is then brought to the Vital Statistics Office, and we can use that as reliable data. So that's why the next few slides that I'm going to present are focused on deaths due to overdoses. So let's talk about what this looks like. Now, one of the ways we use epidemiology to talk about person, place, and time is to be able to use the data to tell the story. So we're going to use the data today to tell the story about the opioid epidemic. And so first we're going to focus on time. So this data shows us from 2000 to 2017 deaths due to overdoses in Maine. And what this data shows us, so the orange is any overdose, and the bluish purple is any opioid. And then the gray is non-pharmaceutical fentanyl. This piece of data alone tells a very, very serious, significant story. We have seen over the past 17 years, the number of overdoses in the state of Maine has dramatically increased. You don't need to be an epidemiologist to take that piece of information away from this table. And what we can see is one of the significant contributors to that is fentanyl. So to put it into context, this is just a depiction of the power and the potency of fentanyl and carfentanil. Basically, what you see in the heroin bottle is the potency that's equivalent to fentanyl and carfentanil. So you can see that maybe about a teaspoon of heroin is about the same potency as just a little flake of carfentanil. And that's what's been added to heroin because of reducing the cost and also providing a stronger high. So fentanyl is 50 times stronger than heroin, and carfentanil is 5,000 times stronger than heroin. We use these type of synthetics to, again, tell a little bit more of a story about the opioid epidemic. We often in epidemiology describe the opioid epidemic happening in 3 waves. The first wave, as we can see in purple, being natural and semi-synthetic opiates like oxycodone and hydrocodone. Those are the prescription narcotics. And then in the orange, we see the rise in overdose deaths due to heroin. And then again, we see the dramatic increase in overdose deaths due to fentanyl and other synthetic opiates. This story tells us about how people who have been managing predominantly physical and mental pain with opioids transition to potentially heroin and then on to fentanyl. That is not what happens in everybody's life, but the data definitely indicates to us that through these 3 waves, we have seen the epidemic change significantly. So this is just another way of looking at opioid deaths in Maine. What jumps out to you about this graph? Just take a second to look at it. So the orange is Maine, and the blue is the United States. Maine is significantly higher than the US average of deaths due to overdoses. So let's talk a little bit more about place. So this is clearly a map of the United States, and we know through research and epidemiology that one of the contributing factors around the opiate epidemic is the mismanagement of pain through prescriptions for opiates. So this is a map that shows us long-lasting opiate prescriptions per 100 people in 2017. The darker the color, the higher the rate. And what we see here is that in New England and in that sort of central Appalachia area, we have a high rate of prescriptions for long-lasting opioids. Not surprisingly, we can then overlay that map with overdose deaths due to opiates. We could almost have, they almost look exactly the same. Again, opiate prescriptions not the only reason for overdose deaths. We've been seeing overdose deaths due to heroin and other synthetics before we had problems with prescription medications for chronic pain mismanagement. But what we can see is that there's significant overlap between the two indicators. Maine is 6th. There is good news. So as an epidemiologist using data, I don't always have a bad message. There's also a good message. For those who are familiar, there was very significant policy that was passed recently in the state of Maine that regulated how opiates were prescribed and a system for tapering people off of opioid medications. And we can see in this chart the percent of decrease in long-acting opiate prescriptions from 2016 to 2017. And Maine has worked really hard in this area. So now let's talk a little bit about person. We've talked about time, we've talked about place, let's talk a little bit about person. This table to me could tell a million stories. If I said to you, what are the leading causes of death in the state of Maine for all ages, all races, all genders? We would say cancer, and we would say heart disease and diabetes. But that doesn't tell the whole story. When we break leading cause of death down by age category, it tells a little bit of a different story. We can see that from the ages of 1 to 44, unintentional injury is the leading cause of death. Opioid overdoses are included in that category. It's often called unintentional poisonings. Overdoses, along with motor vehicle crashes, basically are the leading cause of death in that unintentional injury category. And this is again represented here when we look at age and gender. We can see that males are disproportionately affected by opioid overdoses, in addition to the age group of 25 to 44. And again, this is around opioid overdoses. And again, there's a lot of research that indicates why males may be disproportionately affected. There's some research to indicate that males may actually be maybe taking heroin or other synthetic opioids alone, which results in a high risk for an opioid death if they are not with somebody to help them. And while we have very little diversity, racially speaking, in the state of Maine, it is very important to still look at the data by race and ethnicity. And while you may not be able to see that very clearly, and there's a lot of numbers, the take-home message here is when we look at the rate of change from 2016 to 2017 in terms of overdose deaths involving heroin and synthetic opioids, we see a dramatic increase among Black, non-Hispanic, and American Indian, Alaska Native between the 2 years. So where we have actually seen a decrease in overdose deaths related to heroin in the white, non-Hispanic population, we are seeing dramatic increases in other races and ethnicities. And that is very important to consider. So I can stand up here for hours and talk about the data, about the numbers that are behind the opioid epidemic. But as an epidemiologist, and what we all need to remember is those numbers represent people, human beings who have struggled with opioid use disorder. Portland Press Herald did an amazing story, a series some time ago, where it told the story of those who have died of an overdose death in the state of Maine. And it represented not only the lives that we've lost here in our community, but the families and the friends and the communities that are mourning. So while I can present data, we need to remember that there's people behind that data. Included in those people is the woman in pink. She's alive today, but has overdosed a number of times. The lady in pink is my mom. And as an epidemiologist, I can count all the numbers that I want, but it's the people behind those numbers. And as I talk to you, I'm sure that many of you out there are affected by the epidemic by someone in your family, your friend circle, or your community. And as healthcare providers, you are no doubt going to be seeing the people behind those numbers. So in summary, 1 opioid overdose death a day in the state of Maine, and many other bullet points that we just discussed around person, place, and time. So I'm going to transition a little bit about stigma. So why is this happening? Why are we seeing increases? Why are we seeing certain populations more affected than others? Why is Maine having such a problem? There is no one answer to this, and as an epidemiologist, it's not important to look at the data, but to understand the why. It's due to the social determinants of health. It's being affected by adverse childhood events. It's affected by mismanagement of chronic physical and mental pain by not just providers, but also patients. It's also been affected by stigma. Stigma because people who are struggling with OUD delay healthcare. And also because all those things that you talked about at your table, people who are struggling with OUD believe that about themselves. And so this is just a visual depiction of what stigma is like. So within that circle of power, stigma is influenced by social exclusion, discrimination, stereotyping, and labeling, many of the things that you talked about. There's actually a really great study that was done in 2019 that came out of Massachusetts. It's there for your reference, but these are the high points. They did a qualitative study where they did a focus group and key informant interviews with people who inject drugs. And basically what they said is that for their strategies are delaying healthcare, delaying until they have abscesses that are so infected that they may need to be hospitalized. They're delaying until they are experiencing overdoses. With their healthcare providers, they're not disclosing their drug use. They're downplaying their pain, so they don't want their healthcare providers to think that they are only on a mission to seek prescriptions. And they are seeking care elsewhere, and maybe not with a primary care physician or with somebody that they see on a regular basis. There is good news. The participants in the study said that they feel most comfortable in more like community-based organizations that provide care, including federally qualified health centers, local health departments, and institutions that provide an interprofessional approach. They feel more stigmatized being in a large healthcare organization, except where there is an addiction medicine specialist. And so now I'm just going to play a brief video about stigma and language.
That's right, and this is why all of our discussions today are so frustrating. There are a lot of diseases out there for which we don't have a cure, we don't have a treatment, we don't have prevention, and we really struggle with those and we need more research. And yes, we need more research when it comes to opioids as well. But we actually know what works. And to your question earlier, Lenny, about why has this been so different from any other public health crisis, there's one word: stigma. There are myths and misconceptions around the disease of addiction that's very different from other illnesses. I hear, for example, in Baltimore, you had mentioned that we've been putting out our antidote medication, Narcan or naloxone. I wrote a blanket prescription for this medication to every single one of our 620,000 residents because everyone should be able to save a life. And yet I hear people all the time say, well, why give this medication to people? Isn't that just going to make them use more drugs? Would you ever say to someone who is dying from a peanut allergy, I'm sorry, I'm not going to give you an EpiPen because it might make you eat more peanuts next time? Right? We don't hear that. Naloxone works. It's immediately life-saving. It's non-addictive. It's safe. And we have to save someone's life today to get them into treatment tomorrow. So that's one thing that works, and yet we don't have nearly enough of it because of stigma. There's also huge stigma around treatment. We don't say to someone with diabetes, well, why are you still on insulin? Why can't you get off of your insulin, and isn't lifestyle changes, shouldn't that be enough? And yet we make those assumptions about people with the disease of addiction all the time.
And with regard to Suboxone and methadone.
That's right. When actually the science is clear that medication-assisted treatment with methadone, buprenorphine, combined with psychosocial counseling are what works for the treatment of addiction. And for so long, we have treated addiction as a moral failing, as a crime. I go back to what I think are Senator Markey's excellent points about a whole generation of people who we have to apologize to. In Baltimore City, I've had our residents at community forums come up to me and say, I don't understand why suddenly the opioid epidemic is a public health crisis. Why is it an emergency when it's been a state of emergency my entire life? Because it was poor minorities in inner cities who had this illness, and therefore it was seen as a choice and a moral failing. Therefore, if you end up in jail or dead, it's your fault. I'm glad that we're now seeing it as a disease, but then we need to treat it as any other disease and devote the resources that are necessary to fight it.
And very quickly, how many people, what percentage of the people who need it get treatment?
The Surgeon General's report said that it's about 1 in 10 people. 1 in 10 people with the disease of addiction are able to get the help that they need. Now, what other disease would we find that to be acceptable, right? Would we find it acceptable if only 1 in 10 people with cancer can get chemotherapy?
In my time trying to understand the opioid epidemic and stigma, that's probably one of the best videos that I have ever seen that really hits on the important concepts that we need to understand as professionals and community members. Can I get back to the presentation? So one of the key points that she hits on is the idea of language and how it relates to stigma. We've learned at an early age that words matter and that words can hurt. And there are words associated with people who are struggling with OUD that can be stigmatizing. We may not use them in a way meant to stigmatize, but they do. And this provides a chart, and are we sharing the slides? We'll be sharing the slides so that you can learn what are the words that you may need to substitute for. I've called my mom an addict. My mom at the hospital bed, as I talked to her healthcare provider, I used the word addict. I did not understand how deflating and worthless my mother felt by using that word. My mom is not an addict. My mom is a person who is struggling with substance use disorder. She is a person. She's an avid reader. She's a Special Olympics volunteer. And she's the grandmother to my children. Just like everybody else who is struggling, they are people, and our language needs to be watched carefully. So when you get this slide presentation, I highly recommend that you check your language and what you're using, not only as healthcare providers and professionals, but also as community members. So what I would like you to do as a sort of a closing exercise is I want you to go back through your table and to talk about one way that you feel that you can support the opioid epidemic to move in the right direction, to support people who are struggling, and to prevent stigma from spreading. So let's take 60 seconds for each one of you to go around your table and mention one thing in a role that you could play. So in closing, I have a few recommendations as healthcare providers and community members that I hope you can take away from my presentation. One is look at the data. Look at the data for your community and how it's being affected. Look at it in terms of time, place, and person so that you can fully understand the health issue, including the opioid epidemic, and what the facts are. And use that data to tell a story. Also, what I hope that you walk away with from this presentation is that you do have a role as a healthcare provider and as a community member to spread the facts, to look for those opportunities to reduce stigma and to bring people who are struggling into healthcare, into a community. Thank you.
Wow, thank you, Jen. Do we have any public health students in the audience? Oh, that's unfortunate. Okay, I hope they're getting this. Dr. Norris, would you like to come get into some of the depth here?
Yeah, before the slides. These are not my slides, so if I keep kind of gopping around and looking like I don't know what's next, it's because I don't know what's next and I'm gopping around. But I want to...
Very good at improvising.
I am. You should see my floor routine. So we've talked about the epidemiology. One additional plug I would make for stigmatizing language is consider using opioid or benzo or whatever as opposed to narcotic, since a narcotic is a forensic term and implies you're in possession of something illegal, which is not actually important to the wellness part of it. Another thing I want to just, when we hear statistics, it reminds us that we as healthcare professionals only get to have opinions when there isn't data. Otherwise, it's malpractice. If we just practice according to an opinion instead of the research, when we have research that exists, we don't get to do that. We have to actually look at the latest and best data. And as you said, the data changes all the time, but for the most part, trending. There has been evidence on the appropriate way to treat opioid use disorder and techniques for doing it for decades, but because of the perception that it's a crutch or you should be able to, all the language that we talked about, there is a construct that this isn't necessary. For the record, the meme about why did junkies get the free methadone? No one gets free methadone. It's paid for as a medication. People pay actually a great cost to be in treatment for a methadone program. Another thing to consider, for those of you who probably weren't practicing any healthcare in Maine in 2017, the law came out of immediate restriction of the volume of opioids, but there was not a concomitant increase in access to treatment. And so while the prescriptions for opioids went down, the overdose fatalities went up. And part of this was because I can't give you a drug problem by giving you opioids if you don't have a substance use disorder. You may get your first exposure that way, but I can't, bam, like your wicked stepmother, give you this problem just by prescribing. Otherwise, everyone who ever had a hip replacement should have a problem with substance use disorder, and they don't. Similarly, I can't fix your substance use disorder by just taking away your substance. I have to actually create a multidisciplinary approach to your treatment, and you have to be able to get to the treatment in question. So I really, I know I'm preaching to the choir here, but you guys are going to go out and find non-choir members who are still dropping knowledge like Suboxone is just one drug for another drug, and then waiting around for the applause for their huge knowledge that they just busted out because they're the first person ever to say that. Why don't we start off with a slide of the neurobiology of addiction to get back into the data.
We have a little video here.
For all you visual learners out there.
Right.
To understand the complexities of addiction and its neurobiology, it's important to understand the brain's reward pathway. Information travels through the VTA area to the nucleus accumbens to the prefrontal cortex. These reward pathways make us feel pleasure and are activated by stimuli such as food, water, or sex. These same areas are also involved in addiction. Alcohol and drug use changes the way the brain works. You can see a normal functioning brain on the left and the abnormal functioning addicted brain on the right. Prolonged use of alcohol and drugs also changes the structure of the brain. You can see the normal healthy brain structure on the left and the abnormal addicted brain structure on the right, which could be long-lasting.
I like this one better. I don't know if any of you are old enough to remember the whole "this is your brain on drugs" thing with the frying egg. I like this one better. It's also more representative because we're seeing, for those of you who don't do radiology stuff, that's the activity of a brain, the different colors. It's kind of how the brain is functioning. And it's important to consider if somebody is brand new in recovery and they've been abstinent from whatever for about a week or two, they don't have a brain that's going to be effective doing aggressive, let me look at my toolbox and my recovery assets and they really are not safe and are not making good decisions any more than somebody who had a mechanical brain injury. We need to remember that somebody's brain is not normal in its function the same way someone who had a certain kind of stroke isn't normal, or someone who got hit in the head. Can they get normal with the right intervention? Most of the time, yes, but we have to be realistic. And Mr. Danzig will talk a little more. When people are new, they aren't able to do the kind of processing that we expect of them, and then their families get mad at them because they're not immediately better after 2 weeks in rehab. So that's a really important consideration. How are you guys with your espert chops? Chirp, 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 chirp. Have you guys worked with this? Anybody?
And in Biddeford?
Okay. And in Biddeford? Any Biddo folks coming out? Okay. What do we screen anything for? We screen for a condition that is common within a particular population. I think the idea that this is a common condition within Maine is well-covered territory, so it needs to be screened for. Trick question. Can you look at me and tell me whether or not I have a substance use disorder? I have worked in many an emergency department where people do believe they had this psychic ability. Seems like a nice guy is apparently a rubric of they must not have a problem. Looks like a dirt bag, also people have as a positive predictive role for diagnosing substance use disorder. But can we really? And does anybody come in, who thinks that most people come in and disclose, I've been eating up all my pain meds? I've literally never had that happen, and I actually treat substance use disorder. Because why? There's so much shame. People act like they wet their pants, that they just don't have self-control. They've got everyone in their life giving a hard time. Some are genuinely in pain, and they're afraid of losing access to pain management. So these are a lot of different screening tools. There are many good ones out of there. The most important part is if you are going to screen somebody for substance use disorder, you need to be ready to understand what you're going to do if they have positive things, and you need to create a non-judgmental environment because no one's going to tell you anything. Simply asking a question won't get you the answer. Next slide. These are more than red flags. These are flashing red lights. I have never, somebody who has those kind of track marks is probably not going to walk around in that kind of shirt. What you might notice is it July and they're wearing a hoodie? Are they having what we call role failure, loss of function? Are they not showing up for work? Do you have someone who has no apparent reason to keep complaining of constipation, but yet they're always constipated? That's a big one. And also, obviously, aberrant tox tests. Think about people's relationship with their meds. Say you have someone on a controlled substance. If they're frantically calling every day, does my refill in? Have you done my refill? That implies that there's a little more importance to the conversation than is normal for a particular patient. So be thinking about that. Be thinking about I don't have a particular relationship with my blood pressure meds except that I take it, but there's certain meds that people will get this kind of cold dead hands relationship with, and that's something to really bear in mind. Next slide. You'll get these slides. So short version, there are escalating amounts in a short amount of time. Maybe you start with 3 hydrocodone a day after a dental procedure, and then you're saying, no, I need more and more and more. Continued use despite adverse consequences, that's sort of the hallmark of substance use disorder. If I'm using a medication appropriately and I never have a problem and I'm showing up to work and I'm taking care of my kids and my friends still like me as much as they ever did, then I'm not having adverse consequences. I'm actually functioning well on my medication. If everything in my life is going sideways as a result of whatever it is I'm doing, whether it's alcohol, whether it's cannabis, that's a substance use disorder. Is there another slide? And we're going to move on, but we're going to get back to MAT and how we can apply this for the actual evidence-based treatment for this condition. Thanks.
Thank you, Dr. Norris. She brings a wealth of experience and expertise. I'm grateful to have her. Dr. Dornblasser, you are up. Should introduce you.
Sure.
Let's dance. This is Dr. Emily Dornblasser. She's in the College of Pharmacy and is going to talk to you about the medications that we use here.
Great. All right. So as a pharmacist, I could geek out over medications for hours, but I'll try to keep this short. And my goal is really to introduce
Your students are going to class, right?
Oh, bye, guys. I'll teach you this later, I suppose. But this is important. So these are the medications available for medication-assisted treatment. So a couple things. I want to identify the top 3 medications, the 3 that are out there and available. And I've broken them down based on mechanism of action because I think understanding how these works, to me, helps combat the idea of substituting one medication for the other. So thinking about why it is that we're selecting these medications for treatment helps us understand why they're effective in providing assistance in treatment. So we have methadone, which is a receptor agonist, an opiate receptor agonist. There's buprenorphine, often combined with naloxone. That's commonly known as Suboxone. And then naloxone, which frequently is given as an IM injection, and many people know it as Vivitrol. And that one is just a pure receptor antagonist, meaning that it blocks the receptor completely. So when we look at methadone as an opiate agonist, basically how this works is that it's capable of providing action at the opiate receptor for a long period of time. And when we talk about medications, we talk about half-lives, which is how long it takes for that drug to clear from the body. So a medication with a very long half-life means that it doesn't clear from the body very quickly. And as a result, you don't have massive peaks and troughs or high concentrations and low concentrations as you give this medication. And as a result, there's a lower sort of high, and this person remains on sort of a steady regimen, which helps prevent withdrawal symptoms from occurring in this person. And so if you can remove the withdrawal symptoms that someone's experiencing, you begin to diminish the panic that's associated with the wearing off effect of that opiate. This medication is available through medication assistance treatment programs, and they're federally licensed opiate treatment programs. So these are through quote-unquote methadone clinics. Many patients start on a daily observed administration, and once those patients begin working through some of the therapy associated with becoming more consistent and regular in their administration and taking of the medication, they can transition to a take-home regimen. So this is a fairly intensive regimen to start with. If you consider your daily life need to go to a clinic to receive a medication on a daily basis, really being able to move to a take-home regimen is much more helpful for patients. Think about how intrusive that could be to your day. But it's a very effective medication. We probably have the longest data in terms of usage. So in terms of pros, probably got the longest clinical evidence associated with it. It's very safe in pregnancy and breastfeeding. The cons are that it does have a long half-life. You can have sedation associated with it. Some of the bigger ones from a pharmacy standpoint are QTC prolongation. This can be life-threatening. So we do need to screen medications that patients are on. And it does have complex kinetics. So this isn't a matter of just converting directly from one dosage to another. This can take some time and experience and shouldn't really be done just quickly. So the next one we'll talk about is Suboxone, or buprenorphine and naloxone combined. Now this one's interesting because there's partial agonism, meaning that you're getting some effect at that opiate receptor, which will prevent those withdrawal effects from occurring. But there's also an antagonist, which is naloxone. So we know naloxone completely blocks the opiate receptor and dissociates any opiate from it. So why would we combine these two? And the answer is that buprenorphine in and of itself provides the relief of withdrawal symptoms by agonizing that opiate receptor. And naloxone, when taken orally, as Suboxone is it doesn't have a lot of absorption. So it's really just there in background. It's meant to prevent somebody from potentially crushing the medication and injecting it in an abuse manner. That naloxone would then become active in the IV formulation and prevent abuse. So that's why that naloxone's there. The interesting thing about buprenorphine is that it has one of the highest affinities for the mu receptor, meaning that this drug, when you are giving buprenorphine, it's going to grab onto that opiate receptor and it's not going to let go. So in the presence of other opiates that may be abused, those opiates are not going to bind to that receptor. So the idea is that this actually blocks some of that positive reinforcement effect that's driving addiction in the background when we talked about the neurobiology of addiction. So potentially having buprenorphine on board helps prevent the value of using another substance on top of buprenorphine. So this one can be prescribed by anybody who has an X categorization in their DEA number, and you can apply for that. So NPs, PAs, and physicians are all eligible to prescribe. As a result, that does open up some of the access to providers or to patients. There are fewer drug-drug interactions. We're not concerned about QTC with this, so it seems to be somewhat safer from a dosing and drug interaction perspective. Some of the cons is that because there is agonism and antagonism, it can trigger an early withdrawal. So you really need to time the appropriateness of starting somebody on this. You should not be giving this medication if they're currently actively using an opiate, because it will dissociate all of those opiates off that receptor and can throw someone in withdrawal. And that's going to be an incredibly negative experience for them. It can also complicate acute pain management. So say you're on Suboxone, things are going great, and a car runs over your foot. Well, the problem is you've got something that's blocking that receptor, so it's very difficult for you to get pain management while you've got that drug on board. So that can be a complex experience. It does have some street value for people who might be seeking it if they're going into withdrawal, so there is a diversion potential with Suboxone. And then lastly, we'll talk about naltrexone, which is an opiate antagonist. It's very structurally similar to naloxone, so it's just called naltrexone, just slightly different. The important thing about naltrexone from an IM perspective is it's a depot medication, meaning it's given and it lasts for a very long period of time. So it provides complete blockade of opiate receptors. So if you're on naltrexone and you were to take an opiate, that opiate is going to be unable to bind to any of those receptors and create any kind of effect. So its usually place is recommended for prevention of relapse. This is not going to be a drug that you would give to somebody who's actively using an opiate because, again, it would completely dissociate all opiates and throw them into withdrawal. So once you get somebody to a place where they are now no longer actively using, this may be an option there. So the pros, there's no abuse potential, right? Because this is blocking action completely. Nobody really wants to be taking this and getting a high because you wouldn't, right? That's the whole point of this. There's no tolerance, and it's available to all prescribers, so lots of good access here. It's somewhat easy, quote unquote, because it's just a single dose once a month, but that comes with some risks. At the end of that month, as that dose is wearing off, if someone were to consider using again, potentially their tolerance is completely different, and so they may be at risk of overdosing at that time point. It also limits your ability to give an opiate ever again, right? Because for an entire month, their opiate receptors are blocked. So what happens if 2 days after you get this shot, your foot gets run over, right? We have to really be creative with how we can manage pain in that scenario. And so really at least 7 days after therapy, no opiate's going to be effective. So those are some of the considerations for these. So in terms of which medication to use, methadone is associated with the higher retention of treatment. As I said, it's got the best data associated with it. It's been around the longest. There's less data for naltrexone, but it is growing. If you have somebody who might be at risk of relapsing, that'd be something to consider. And then we also want to think about what's available. What is the patient most likely to be most adherent with, and what would be the best patient-centered choice. So I will leave it there.
Thank you, Dr. Dornblasser, who has really, I think, in a very quick period of time, given us the 3 top medicines that are used in medication-assisted treatment so that you can have a grasp on the different types. However, it's not called medication treatment, it's called medication-assisted treatment. So medication is one prong in this treatment regimen. What I'd like you to do now is to think about your own profession, the one that you are going into, and what your profession would bring to medication-assisted treatment, to treatment with people with opioid use disorder. And so I'd like you to think about these 3 questions at your table. What do you think your profession offers to assist in this crisis? How do you think your profession might contribute to MAT? That's medication-assisted treatment. You can add that to your acronym list. And what questions do you then have for your panelists who will follow up on your conversation? So if you could take about 4 to 6 minutes to talk about that, we'll get back with you when you're done. Thank you.
But it'd be interesting because, I mean, since we're talking about opioids, that would be I always like to look at it. Just saying that. I mean, it depends on I'm ordered in it, so yeah. I was on the Reels Network and they called me that.
I think so. Did she used to be Lee's? Or is that a different one? I think it's different. Yeah, she's just in case we will.
So I'm curious, and I may need my friends with a microphone. Which profession would like to start with saying what their contributions would be? It's really distracting when you all, oh, there we go.
I'm in the dental medicine program, and from our...
I'm sorry, I couldn't hear.
I'm from the dental medicine program.
Oh, thank you.
And for some patients, they may see their dentist more often, or they might not have a PCP, and they'll come into the dentist with some chronic pain because they have been putting off treatment. And so being able to know how to identify if someone has the disease or has a concern, and knowing what track to send them, not necessarily treating it yourself, but being that support for them.
Thank you.
Thank you for talking about oral health and dental. In epidemiology, a number of years ago, when we were looking in data in Maine, sort of the first red flag that we missed was looking at the data around leading causes or leading reasons why people went to the emergency department. And throughout the state of Maine, on that list in the top 5 was for dental pain. Some of that was definitely related to the lack of access of having, but a significant proportion of it was around drug-seeking behaviors that we later saw in the prescription monitoring program. But one of our red flags early on with this epidemic was around oral health.
Thanks, Jan. Dr. Stansberry, Tessie, do you want to chime in? Dr. Stansberry is faculty at the College of Dental Medicine.
Yes, no, I agree. We see people in all various stages of substance use disorder, and so we play a big role because we can identify some of these people, as well as provide them resources as far as any type of help that they may need. And also we are big into providing that kind of a safe, non-judgmental place for people to kind of disclose some of these things, because sometimes they are a little apprehensive about disclosing some of these things. So we do kind of offer that, as well as support as far as oral health-wise, offering them, or at least educating them on the different things that can happen based on different medications. For example, opioids can cause dry mouth and also increase people's searching for sugary carb type foods. And so, but those things combined, that can lead to just their teeth kind of just disintegrating. So we kind of offer them education as far as how to protect their teeth, as well as opioids can kind of increase people's ability to kind of clench their teeth together as well, so breaking their teeth. So we offer information at a wide range for people. So we do kind of see them at different stages, as well as we are part of the prescription monitoring program. It's mandatory, as well as mandatory continuing education as far as how to manage patients.
Thank you. Thank you. I think Dr. Norris wanted to chime in on oral health.
I would admonish anyone doing dental work to remember that if a person has substance use disorder, they haven't lost their right to effective analgesia for painful procedures. And in general, people who are in recovery will be delighted if you ask them, now, what are you comfortable with? If somebody used to use a particular thing, I have a lady who used to abuse Vicodin, so when she has stuff, she'll even say, could you please tell my dentist not to give this to me? And I'll say, well, there are other things. Sure, there's a particular feeling of a particular med. Also, many people are very triggered by needles, and that's something to bear in mind for any of us who do procedure stuff.
Thank you. So, great start. Thank you for starting our conversation. I'm going to ask Biddeford, what have you got up there for professions who would like to talk about your contributions to this effort?
Hi, Jen, and hi, Portland campus. We've got a great interprofessional group here. I'm going to pass the mic to Amanda in public health.
Hi. I just talked about how in my potential career, I may be looking at the community, like asking questions like why, looking at trends, getting out in the community and interviewing and working with epidemiologists or healthcare professionals and just looking at trends and reasons why this epidemic is occurring. Thank you.
Jen, would you like to comment?
I just want to say go, Amanda. She's one of my students.
Is she a plant?
No, not at all.
Okay, that's good. Thank you, Amanda. Another profession's contributions that you imagine making for your profession. We've got a hand right here. Jen? Oh, over there? Okay.
So I'm in nursing. I think all of our nursing classes here. I think the big thing that we often talk about is just consistent education with our patients, and also advocacy. Education in that when we are giving them their prescriptions, whatever the provider has given them, to educate them properly on the concerns. I think a lot of patients are aware of, the potential of these opioids, but they may not be. And then advocacy for our patients, as we had talked about earlier, some of the stigma that is around that, and it does still happen with providers. So being advocates to our patients, if their providers are kind of writing them off as addicts and kind of help educating them a little bit more. And then also advocating for our patients with their medications, if we find they are on methadone and Suboxone, and how that's going to affect their treatment and anything else. So those are, I think, in nursing is those two big points.
Thank you very much. And I regret we don't have a practicing nurse with us today, so I'm wondering if any of your other colleagues would like to offer any other thoughts about the important role of nursing in this interprofessional patient care.
So I'm in nursing as well, and on a less technical medical standpoint, I think as a nurse you spend so much time bedside with your patient, and you can really get to know them and just extending empathy. I feel like addiction and opioid abuse or alcoholism is something that we've been talking about this all day. It's so stigmatized, but to give your patient a platform where they feel like they're being heard and understood, I think is so, so important. And then obviously implementing that into their plan of care. But I know personally, I've been to a lot of doctor's appointments where, I don't know, I say anything and I can just see the look in the provider's face. It's immediate judgment. And I think as a nurse, we can look beyond that and at the patient. Empathy.
Thank you. And obviously that is something we're trying to correct right here. Is having empathy regardless of the profession is a really important point. Dr. Norris?
I have had, remember in terms of nursing, in many ways you're spending a lot more time with the patient, particularly if you're in an emergency department setting or you're kind of the first line of communication with the actual health world post, the admin intake. You can't imagine how many patients I have just straight up lie about whether they're on methadone, or when they mention that they're on buprenorphine, they say that she was really nice and she was being really reassuring. And then as soon as I said I was on this med, the whole conversation changed and they kind of withdrew and got weird. And I know no one means to do that, but there's this kind of, if someone tells you they're on methadone or Suboxone, the only thing that should be coming out of your mouth is, good for you. How's your recovery going?
I just want to make a comment about the advocacy that you mentioned. As an epidemiologist, I've testified in front of legislation, and I take out my fancy data and charts and show all the evidence for an issue, and it takes one healthcare provider, a nurse, a physician, a pharmacist, a dentist, whomever, to tell a story about their community, and that's what changes minds. The data helps, but the stories and the advocacy, and it's not just about the stigma, it's about things like school-based health centers. We know that they provide an amazing level of care that's around prevention for a substance use disorder. So I just want to commend you for bringing up advocacy and the role that you have as a healthcare provider and public health professional.
Thank you. How about social work? Do we have any social work students or graduates? Oh, okay.
So as a social worker, definitely interested in helping them with their mental health needs, so counseling services. But I think also what's really important is providing case management to make sure that they are getting to their appointments on time. What other kinds of stressors in their lives can we help them with, whether it's childcare or relationship issues. Am I missing anything else, Jen? Community building, yes.
Great, thank you very much. So, Mr. Danzig, would you like to jump in and maybe list your credentials again, because you have advanced credentials?
Okay, well, my name is Steve Danzig. I am a licensed clinical social worker, a licensed alcohol and drug counselor, a certified clinical supervisor, and I'm also a certified intervention professional, which that last one means I am credentialed with the national licensing body to perform interventions all over the United States. So I just wanted to echo what folks said about nursing, and that really it's the first point of contact. I worked in a detox many years ago, and the nursing staff there was, really what held everything together. Sorry, doctors, if there's anyone in here making eyes at me. But that, that bedside, that empathy that you can show towards the patients that you're working with is going to be tremendously helpful. If you have somebody that's in there that's just started on a pain management regimen or something like that, really knowing what the earmarks are of a problem being created by the use of those going forward, because by and large, most people, they just don't know what's happening. And when somebody points it out to them, they say, no, I've got it. I'm all good. I've got it under control. And they really don't. So just really inundating them with education around the potentials, it may create a stop sign for them down the road. And in terms of social work, I was trying to think about this because I was asked to say, what is social work's role? And I think it's the easier list is probably what isn't social work's role. There is just so much. I think one of the biggest pieces is really having a collaborative relationship with the medical community and with other providers out there, because there's so many services out there, but to really understand and know what each service does and how do we as social workers integrate with that. And when you're going more specifically in substance use disorder and working with that, there's just a whole another range of issues that come with that. Case management is huge, especially if you're working with the homeless population that they just, they've got 50 cents in their pocket and they just need everything. So one of the things I thought about was going through school, that my professors would always say, you can't work harder than your client. I've personally changed that for myself and for the folks that work with me, because somebody's just coming into treatment, they have no idea how difficult this is going to be. They only know where they're starting from, which, you know, it may be the bottom of the bottom, it might be almost there, it might be, you know, maybe they were fortunate and didn't have to go all the way down. But this disease encompasses every single aspect of a person's life, every relationship, their job, their kids, everything. And to try to turn that all over again is just a tremendous, tremendous effort, and it takes a lot of, you know, a multidisciplinary approach to really tackling this. So you are going to work harder than your client at first, but then you're going to see them start to say, you know what, I can do this. And they're going to start to stand up and they're going to do it with your help.
Thank you. I'm curious about Biddeford. Biddeford, do we have another profession that would like to weigh in? Can't hear you, Michelle.
We're good.
Oh.
Thank you.
Okay. Whoops, made me jump. Thank you. How about here? What did we miss? Anybody an outlier that we didn't touch on? Medicine? Can I pick on you, Messina?
So, as osteopathic doctors, we, of course, can become prescribers and be supportive in people who are looking for recovery support from a primary care perspective, and also as somebody going into internal medicine and hospitalist medicine, if we're educated about pain management for people who are using recovery medications, we can help people be set up for support while they're in the hospital and getting out of the hospital in order to maintain both pain management and recovery support.
Can I ask a follow-up question? Because I'd like to know the answer too. As a DO, what do you see the role of manipulative medicine is in chronic pain management and treating substance use disorder?
Well, of course, osteopathic hands-on therapy has ability to support reducing people's pain from a non-pharmacological perspective. And it's also, by doing hands-on therapy, we can provide therapeutic touch and integrate time for patients to integrate their nervous system, their mental, emotional bodies, their physical selves. And so I have the great pleasure of working with Dr. Norris right now and in her primary care practice. And there are many patients that are in for pain management or for recovery that we also do hands-on treatment for because, of course, it's a structure, function, medicine based.
Thank you.
Thank you. Dr. Norris, want to build on that a little bit at all? Would you like to build on that at all? Add or clarify?
One of the things that's the nature of having a substance use disorder is that an overwhelming majority of people who suffer from the condition have a history of trauma and do not regulate well, do not either are hyper-aroused and have an exaggerated pain response, or are blunted and not good at getting out of the way in some situations. So they're disempowered, they don't have good self-efficacy. One of the conversations that you have as a physician or a nurse practitioner or PA is not only when is it appropriate to use meds, especially in the course of MAT, but when is it not appropriate to use meds? What's been interesting is that my recovery folks also always want an antibiotic for everything, even though they may not have a bacterial process. They also always want something for sleep. Not because they're being manipulative, but because their mindset is, if I'm having a thing, I need to take something to modulate it. And maybe their parents did the same thing, and they don't really get, like, I can actually do something, or I can help with getting myself feeling better, particularly around anxiety, particularly around sleep. And the prescriber can really be the educator of not everything is going to be treated with a medication. Sometimes your being anxious is very appropriate and it's part of your threat response, and this is how you know something is a bad idea. And sometimes pain is a really useful stimulus. And look at how much we treated someone today who we had to just get her to calm down while doing manipulation on her because she does this all the time. And she doesn't always realize, like, you're causing your pain right now because you're bunched up. But sometimes if you are somebody who prescribes, you have more credibility by going, look, I can do meds all day long, and meds aren't what you need. I would love it if I could be the hero of this story, but the reality is, here's what needs to happen instead. And that's a pretty important role as far as re-educating the automatic thoughts.
Thank you. Actually, other questions or thoughts from you or from here or Biddeford? Okay, I wanted to give both Dr. Dornblasser and Dr. Stansberry a minute more to elaborate on their roles if they wish, and anybody else who wants to before we, so that we can capture their time since they're here and we can get their wisdom.
My traditional area of practice is in inpatient hospital practice, and one of the roles of the inpatient pharmacist in particular, we do a lot of medication reconciliation. And I work in an ICU, so typically I see sort of anybody and everybody at all spectrums of need for healthcare. And so what I have done has been to be the person on the team that does a reconciliation of methadone doses for people who come in with methadone. There does always tend to be a stigma. We have physicians who do not want to continue the prescription of it, and so I like to serve as the bridge between the clinic and the patient and the team to make sure that the team feels comfortable with the dose that's present, make sure that the patient knows that I've talked to their providers on the outside know that they're here, and that tends to just create a level of comfort with what's about to happen and what the course will be. So to make sure that everybody knows that we're talking. As a pharmacist, oftentimes we're sort of bridging all of the many different interdisciplinary groups that are a part of that profession, and sort of the ones to relay what's the plan, who's going to do the plan, what's the follow-up of the plan, to many of the different care teams. So, for instance, particularly in ASU, people could be running at many different times, and we might be the one person that's going to be up in the unit all day long. So that's one area. And again, also just reconciliation, maybe not just methadone, but those coming in on Suboxone, and making sure that we get the correct dose and that they know that we've talked to their providers as an outpatient and that we're continuing that. Oftentimes, the patients that I have that are acutely agitated, and I have an example where, nobody wanted to go into this patient's room because he was agitated, he was throwing. They had turned his phone off at one point because he was calling people and shouting, and it was, they wanted to call security and have him restrained, and I just walked in and said, like, what's going on? And part of it was he wanted his medications restarted. He was on a dose of Zyprexa, he was on a dose of sertraline, and he was on a Suboxone dose, and he hadn't taken them that morning, and no one was listening to him. And it was just like, tell me what doctors you want me to call, and I will call them, and we will get it ordered. And within 30 minutes, he'd calmed down. And it was just a matter of listening and reconciling medications and not being afraid to go into that room. So from a pharmacist standpoint, I think that's important. I also think, just a quick plug from a prevention standpoint, when you have people getting acute pain prescriptions that are Q6 PRN or Q4 to 6 PRN, does anybody know what that means? And explaining, you do not have to take this every 4 hours. You can take it every 6 hours if you need to. And coming up with a better plan for patients to help them transition off acute care pain meds that includes things like over-the-counter meds, and explaining to them how that all works, because I think sometimes it's patients feel like they might understand, but they don't know how to stop. And we can certainly help with that too.
To piggyback off of some of that, I mean, we see people on all ends of the spectrum as well. And so oftentimes I find myself in different situations, maybe one, just educating patients on some of the resources that are out there, as well as sometimes patients are straight up about it, saying, I don't want any narcotics or opioids when they come in. I mean, we have the walk-in clinic, which pretty much will treat anybody who is in pain. And so what we often do is sometimes those patients are straight up with us and say that they don't want any opioids. We tend to not prescribe as many opioids as we have been known to in the past. Dentists kind of get a bad rap on that because we would pretty much hand out them like candy, but we have taken an active step back as far as prescribing them. And even if we are going to prescribe them, we go through the prescription monitoring program to see if the patient has a history of filling prescriptions, as well as reaching out to providers that maybe that they are already seeing and talking about them if we do feel in the end that maybe this person needs something stronger than over-the-counter stuff. We do push the over-the-counter stuff because studies have shown that combination therapy of NSAIDs and acetaminophen actually work much better than opioids. And so we do tend to push that. But if we find that a patient does need something stronger, we do kind of communicate with the other people that are involved in their care. As well as, we do offer that kind of open environment that sometimes if we see those patients that are at that very first step of considering about, approaching for therapy, that we offer them that kind of non-judgmental environment where they can express their thoughts, their concerns, as well as, just being open and honest with us. I tend to feel that patients sometimes come to see us first before going to see a primary care doctor, and so we can often give them the resources that they might need and find useful. So it's kind of what we do daily.
Wow, thank you. I think that we could have spent an entire afternoon talking about this, and yet I hope that this has given you at least a taste, if it's a beginning session for you, or a little deeper understanding, if it's not a beginning session for you, on these intentions that we had for today. And I encourage you, please, to fill out the evaluation that's on your table and leave it, if you can leave it at the registration table as you come in. We would appreciate that very much. And please join me in thanking our panelists for today. And thank you all. Go out and do good.